aneurysms. Now I invite Ramesh Chandra sir for another interesting topic on posterior circulation aneurysms.
Good morning. I thank the organizing committee for having me here. So I'll be discussing about the posterior circulation aneurysms. Now, surgery for posterior circulation aneurysms is a disappearing art, as you know. So majority undergo the endovascular procedures. So multiple varied surgical approaches are described, but again the approach has to be tailor-made for each patient. And the surgeon dealing with the posterior circulation aneurysm has to have master a unique set of skills, which I will be discussing. Now, as you see here, this is the incidence of all the aneurysms by microsurgical treatment of aneurysms in various series. When you compare to the swim series, you have 10% of that we operate in swims because we don't have an endovascular inside. So we give the option for the patient for endovascular or open. If they are willing to go, then we refer to NIMHANS, which is the nearest government sector doing endovascular coiling. The rest we operate. So that's why the incidence is around 10% at our place. Now coming to classification, various methods of classifications are available. The basilar can be classified as high basilar, mid basilar, vertebrobasilar, depicted in the diagram. And there is always an overlap of the techniques which you do for each type of aneurysm. So usually the approaches are orbitozygomatic, T-rional, subtemporal, transclavial, petrosal, and paralateral. And again, there is a subclassification of each aneurysm. For example, PCA can be divided into proximal PCA 1, 2, 3, 4, depending upon the site of the aneurysm. And again, depending upon the site, the approach also varies. Again, the same thing, there is an overlap of all the approaches. Based upon the sagittal location, based upon the clivus, we can divide into the zones, clival zones, zone 0, 1, 2, and 3, and this is then classify it accordingly. So above the posterior clinoid process, it is zone 0. Again, it has 0A and B, where if it is less than 10 mm of the PCP, and if it is more than 10 mm of the PCP, then zone 1 is from posterior clinoid process to the internal acoustic meatus. Then zone 2 is internal acoustic meatus to jugular tubercle, and 3 is jugular tubercle to foramen magnum. Now again, based upon these, the surgical approaches vary. So for example, if it is just less than 10 mm from the PCP, a T-rional clinoidectomy with an anterior clinoidectomy or plus minus a posterior clinoidectomy can do. If it is more high riding, then the high lying basilar, then maybe we need to do an FTOZ, so that because from the base we need to approach. And from PCP to from the zone 1, again there are variations: temporal craniotomy, zygotomy, osteotomy, subtemporal approach, division of the tent, use of fenestrated clips, and even if it is more less than below the floor of cella, you can do an FTOZ with a Kawase approach. So all basically the approach is not hard and fast that you have to do this approach. It is tailor made as and when the situation arises. So what are the factors to consider? So again, the aneurysm site and site, the origin of the sac, the projection and size of the fundus, relation of the sac with the PCA and the perforators and the pica, depending upon the location of the aneurysm, distance from the sagittal midline. So if it is closer to one side, maybe that side of approach you can do. If it is a high-lying basilar, the PCS both will be down, so the neck will be clear. But again, if the PCA is low-lying, the aneurysm is low-lying, the PCS will be above, and the PCS will come in view of before you reach the neck. So all these factors you have to study the CT angio well when you plan this. Presence of other aneurysm, temporal lobe swelling, presence of intracerebral hemorrhage, all these factors you have to consider before putting the knife to know the approach. Now the skill set. So I was telling some skill set where the surgeon has to master. So the primary approach, I have divided this into primary approach and the adjuncts. So primary approach, everyone knows arterional, subtemporal, FTOZ, half and half approach, far lateral, depending upon the site of the aneurysm, and adjuncts. So you need to know how to do an anterior clinectomy, either an extradural or intradural, how to deroof an optic nerve so that you gain, ultimately, if you want to work between the corridors, you need to have some retraction. But for that, you have to mobilize the carotid, mobilize the optic nerve. For that, you need to do optic nerve deroofing. Then you need to posterior clinodectomy so that you get space between the carotid and the third nerve, and transcavernous approach. Good Sylvian fissure opening should be done. Then stripping the cavernous sinus wall, so to expose the cavasier quadrangle, anterior petrosectomy, cutting the tentorium, drilling the condylar and jugular when you do the far lateral approach, extended retrosigmoid approach, very unique approach where you can directly reach the anterior part of the brainstem, and you should be master the art of using various clipology, what sir had told, and of course bypass is a very adjunctive tool. So it's not hard and fast that I will do this in this case. You have a plan in place, and once you start doing, depending upon the need, whatever structure is obstructing, you can tailor your surgery. So I'll go through some of the cases. It's a basilar top aneurysm. You can see it is the fundus is directed to one side. So careful dissection. So both the corridors we have to open. This is the carotid. I'm working between the carotid and the third nerve here. We can see the trunk of the basilar artery. As you work between the optic nerve and the carotid, the aneurysm is seen here. I have run the video fast, so you can see these are both the PCS, the SCS and the basilar trunk. Confirmation with an ICG. The high-lying basilar top, FTOZ was done here. So you first mobilize the third nerve. To create space with the liliquous membrane. Here you can see you trace the PCOM to reach the PCA, and you trace the PCA back to reach the basilar. So you can see the carotid, the PCOM joining the PCA here. Now the PCA is joining the basilar trunk here. So I am exposing the basilar trunk to have control. You always make sure that you have some control to apply the temporary clip. Now this is the opposite PCA seen here. This is the aneurysm. This is again another, this was almost near the posterior clinoid process. Either a subtemporal or FTOZ would have been done. So we did an FTOZ. This is the intradural drilling of the anterior clinoid process. You can use a drill or a CUSA or a bone scalpel to mobilize the carotid, cutting the proximal dural ring, because you need to work between the carotid and the third nerve. Transcavernous, you are cutting the cavernous portion of the exposing the cavernous part of the third nerve to mobilize it, because we need to go here. This is the posterior clinoid process here. So you create place here, do the posterior clinoidectomy. Again, bones CUSA comes in hand. There will be a bleeding from the posterior. Once you enter there, can be stopped with a little amount of fibrin glue. So now you got a nice corridor between the third nerve and the carotid after removing the clinoid process, posterior clinoid. So this is the aneurysm here. This is the basilar trunk. This is the PCA here. Opposite PCA. ICG was done. So sometimes we use the adenosine-induced cardiac arrest. In this patient, we had used the adenosine-induced cardiac arrest. Now the adenosine-induced cardiac arrest will give you 6 to 10 seconds of time. So it's an alternative to temporary clipping. But before giving the adenosine, you put your clips in place. You find where exactly you want to put the clip, and you don't close the clip there. So wait for the adenosine to be given so that the sac softens and it comes into the clip. Now adenosine has been given, so now it's asystole there. So that will last for around 6 to 10 seconds at the max. Now you release your clip, and at the same immediately we reinforce it with another clip. This is an interesting case, a basilar trunk aneurysm. So we did a transcavernous approach. You mobilize both the